apologize for that, but Dr. Mccreary is on a tight schedule, and I do hope in return that we'll be able to get you out of here a little bit earlier this afternoon. So without further delay, let me introduce to you our next presenter. This is Dr. Brian McCrary, and he is a colonel and senior flight surgeon in the United States Air Force. He obtained his degree, Doctor of Osteopathy degree, in 1985 from Des Moines University, and then went on to get a master's in public health degree from the University of Arizona, and that was in 1993. He is board certified in occupational and aerospace medicine, as well as undersea and hyperbaric medicine. He is also a fellow of the American College of Preventive Medicine and a fellow of the American College of Occupational and Environmental Medicine. He is active in several professional associations and has given numerous presentations, as well as authoring numerous publications related to occupational medicine. And as you can see here, he's going to talk to us about the clinical indications for hyperbaric oxygen, which I think is a very fascinating thing, and something we can all learn more about. So without further ado, let me introduce to you Dr. Mccreary.
Thank you. Well, I'm also a fellow of the Wound Care Association, which is what you guys are doing. And CWS degree, the Certified Wound Specialist, is something you can get, and it is a recognized accreditation for nurses. I would recommend you do it. I'm really glad they're doing this because wound care is a very neglected area of education for a lot of nurses. Just came from an Air Force Medical Center, Travis Air Force Base. It's our largest medical center once Wilford Hall downsizes. And other than my nurse and I, nobody really had a clue about wound care. And that's pretty shocking when you realize that that's a lot of what you do. Same with the physicians, the surgeons, the vascular surgeons, they didn't have a clue. They were doing wet to dry, which is, I'm sure you've probably heard, 30 to 40 years out of date, and all this sort of, that's all they know how to do. I'm very glad they're doing this. I'm sorry I have the dreaded after lunch talk, but I'll try and make it interesting. I thought I was going to be talking about wound care at first, and then last minute they said, oh no, you're going to be doing about hyperbarics. Well, that's great. I love talking about hyperbarics. This is actually at Randolph, but I just recently came from Travis, which has the largest combined wound care and hyperbaric center in the country. So this is what I was doing full-time. I'm doing it part-time here now. This is where the rubber meets the road. These are I'm just going to talk about the approved indications for hyperbarics. Not all of these are wound care. So I'll brush over the ones that are not wound care related pretty quick. There's only 13 approved indications. You think you ought to know what they are so you can consider referrals. And then at the end we'll talk a little bit about some of the experimental uses. There's lots and lots of them actually, but some of them that have a lot more validity than others. And you guys can be the ones to suggest that, well, you know what about trying hyperbaric? Because some of these are pretty compelling in the evidence form. So this is what we're going to talk about. I'm not going to just read off this list. We're going to go through each one of these briefly. Like I said, the ones that aren't related to wound care, we're going to go over pretty fast. But there's 13 approved indications. These are the 13, and then some of the experimental uses. Hyperbarics is treatment with 100% oxygen inhaled in a pressurized environment. It's not just pressurizing air. It has to be oxygen for it to be hyperbaric oxygen. In 1975, there were over 125 indications. Some of these were valid, but they didn't have enough evidence to really support them. We're gradually building that up. Hyperbarics has been very maligned. It's been used as an alternative medicine type of thing for a while. People are putting chambers in their garage and treating people. And so we are very evidence-based. Our randomized controlled studies are very powerful studies we have that allowed us to get these 13 approved indications in 1996. And then a 14th one, I believe, has been approved or will be approved with a new edition, and it's one that I basically champion. This is the oldest working chamber in the world. This is the Panama Chamber, used in the Panama Canal, and it's still used at Brooks Air Force Base. We would treat decompression sickness cases in there, and I remember it most because I used to sleep in there. And we'd take call, and during fellowship, you're there a lot at night, treating a lot of these decompression sickness cases from the altitude chamber, and they're usually 5 or 6 hour dives. So of course they always wait until midnight or so to call you. They don't ever, when they first feel it, they wait until the middle of the night. And so there's many a times I would crawl in there and sleep on some mats in there for a few hours. And it's very comfortable inside, very quiet. This is actually wrong. Michael Jackson did not do this. This was published very widely, and everybody said, "Oh, he's trying to live forever and trying to not age." Hyperbarics doesn't do that, for one thing. But what actually happened is he bought this chamber 20 years ago, donated it to a children's hospital. They asked him to climb in and take a picture, and this was circulated all over the world. All these fake stories about it. Another thing it doesn't work for. It's one where they just put somebody's picture in there. That's not Reagan. So these are the mechanisms of action. Pressure, you're squeezing. So if you've got a bubble, you're squeezing that bubble, making it smaller, letting it try and get through the circulation. Oxygen diffusion is the big one. If you've got nitrogen bubbles, you're creating this huge oxygen gradient for the nitrogen to diffuse out very, very rapidly. So it gets rid of it real quickly. Hyperoxygenating tissues, not only 100% oxygenation of the blood, but the plasma. There's actually a study they did where they took baby pigs and totally exsanguinated them in the chamber and infused a plasma type solution. And of course, they're all like this. And as soon as they pressurized the chamber, took it to 2 atmospheres, they're running around like normal. The plasma can carry enough oxygen to completely supply the body's needs. Then when they took the chamber back up to the surface, they all collapsed again. Downregulates vasoconstriction. That's why it's very important. It reduces edema. It's used a lot of times for lymphedema. We use it for compartment syndromes. It compresses the vessels, reduces the edema by 20%. Downregulates inflammatory cytokinase. So anytime you've got an inflammatory process, some of these self-perpetuate themselves, as you know, ischemia reperfusion. I'll mention that several times. A lot of times with a crush injury or a cut, it self-perpetuates and just keeps an inflammatory cascade going. It stops that, shuts it down. Upregulates growth factors, which are critical for wound care, for healing wounds, particularly stubborn chronic wounds. Enhances white blood cell action, kills bacteria, and activates a number of toxins. Those are just the basic mechanisms. There's a whole bunch more, but I'm not going to go into that. This was the chamber we had at Travis. This was actually 3 interconnected chambers. This one back here had a bathroom, so we had a little latrine sign above it. These could be taken down separately or as one unit. Usually we took just one at a time down. This was a big one. You could put 50 people in this chamber, 18 patients. The only time we ever used all 3 was while I was there. We had our normal wound care dive going on. We had a hospitalized patient with necrotizing fasciitis in here, and then another emergency, like a carbon monoxide came in. We were doing all 3. First time ever that we did that. There's a very similar chamber at Wright-Patterson in Ohio, too. That's where just heading in. Now, a lot of places don't have these multi-place chambers. Most places you'll see have these monoplace that I'm going to show you. These are a real luxury. You can monitor the patient, you can be bagging them, you can be giving them everything under the sun, heart monitor, and so on. The monoplace chamber can do a lot of that through little ports, but you can't get to the patient, you can't touch them. I'm not saying that that's a bad deal, because you can take care of most things, but it's really a nice luxury. And that's what it was like inside. Each one of these is an oxygen breathing port. These are fire suppression systems up above. Now this is your typical hospital. These are little Seacrest monoplace chambers, and they're making them bigger and bigger as people get fatter and fatter. And each person, you get on a stretcher and it just locks up here, and the thing just rolls inside. This is your little control panel. That's how you talk to them. There's a speaker in there. And they can watch the TV through the acrylic port, but you can't get to them. It has some little things here, so you can have a heart monitor. You can have a certain ventilators and things like that attached, but you can't get right to them. But that's what most places do, and just in and out throughout the day. It's much cheaper. Our unit was about $3 million, which was built about 18 years ago. These cost between 100 and 150,000. Yeah.
You want to back
Sure.
if you have to get a patient out,
You can get them out within about a minute. You can depressurize and get them out in about a minute, minute and a half, if you absolutely have to. But you do risk rupturing eardrums. And if they're having a seizure, you'd like to get to them right away, which can happen. Oxygen toxicity seizures, they're rare, but they can happen. This is the Perry chamber. This is one of the nicer chamber monoplace. You can actually, mom can sit in there and hold her child, so they're kind of nice. You can sit up in those. We have one of those. This is one of the stretchers. They have a little bed, a cot, and it fits on there, and it just marries up with these little things, and you slide it in. It's very easy, just in and out, very simple. And you just wipe the thing down and then put the next patient in. That's the oxygen hood in the multi-place chamber. In those, you're pressurizing air. You don't want to have that whole thing be oxygen. You're pressurizing air and you're delivering oxygen through a hood. In the monoplace chamber, the whole thing is oxygen. So more of a fire hazard. And they have portable chambers. The Air Force came up with this, and this has been fielded around the world for emergencies. Anyway, primary treatment for decompression sickness, air gas embolism, and acute carbon monoxide poisoning. All the other things that we use hyperbarics for, it's adjunctive, along with antibiotics or surgery or whatever. We'll talk about those. And again, we'll go through each one of these, so I'm not going to talk about them right here. This was an old Navy Drager chamber. They still use these on some of their vessels. And this thing actually hooks in there, and it's a two-man chamber. The attendant sits here, and the patient straddles there between their legs. And they're all fine. They're fine. It's just there's newer things. So number one, air gas embolism. This is not a wound care thing, so we'll try and brush through it pretty quick. When you get an embolism, when you get an air bubble in the vessel, it acts like a foreign body. You get inflammation and edema, irritation, cell injury, and you're not getting blood flow through. This happens with diving when they come up too rapidly and they're holding their breath. This can happen in as little as 3.5 feet of water. So there's instances where Dad just finished scuba diving course and he's scuba diving at the bottom of his 5-foot pool, and sun comes down and, hey Dad, and Dad gives him some air to breathe, and he holds his breath, comes to the surface, and ruptures his lungs. People have died as low as 3.5 feet of water because the air is concentrated. It's very concentrated, and it's most concentrated the first 10 feet. So we go very slow the first 10 feet that we go down. Well, so your lungs are actually full, they're packed with air, and then you're breathing in very condensed air, holding your breath and going to the surface. It expands tremendously, and you rupture. So this can happen with some of the submarine escape training. People that wouldn't. If you've ever done scuba diving, you're told when you ascend, you go ah the whole way because you're letting the air go out. If you don't do that, so they come up to the surface, they're unconscious, they typically groan, which is the air coming out raw, and bloody sputum. And so those are emergency treatments. Submarine escape training is one of them where they have. I actually went through this, but they have a tube that's about 10 feet, and you exit through that. But other causes where you could see this, and we did see some real emergency ones, are vascular, cardiac surgery, catheterizations, endoscopies, OB. Any place where they're introducing air or carbon dioxide through a catheter or something, and they're doing a procedure that can get into an artery and cause arterial gas embolism. You can have it with traumas, accidents, even auto accidents. And these are a real emergency, and the results are amazing. We treated one person that was in a coma, seizing from a procedure. They did an MRI. Instead of getting him right down to hyperbarics, they went and did an MRI and showed massive bubbles all throughout his organs and his brain. And we treated him. We didn't get him till about an hour and 20 minutes. I kept saying, get him down there, get him down. We finally got him down there, and within 30 minutes he was fine, completely recovered. He would have been permanently in a coma or died. So hyperbaric treatment, better outcome, improves everything. It reduces the edema, oxygenates the ischemic tissues, particularly in the brain, and reduces this ischemia reperfusion injury. As I said, it's a self-perpetuating injury that you will see anytime you have crush or cuts and something that keeps spreading and spreading, like burns are real common for this. It just keeps perpetuating and spreading the tissue damage. That's what ischemia reperfusion is, and it kind of stops that. We don't need to talk about the tables. Hyperbarics will reduce the bubble size if you've got an air bubble or a nitrogen bubble. It reduces the volume a lot more than the diameter. That's just the way a bubble works. Volume goes down, but diameter needs to go down as much. So this is about the maximum depth you would treat someone with oxygen. This is the maximum depth you treat, period, but you only use air. The oxygen would be too toxic. So you see, even at the maximum depth you could take someone, you're only reducing the diameter of the bubble by half, but the volume is much reduced. And then the oxygen, the excess oxygen on the outside, the diffusion gradient it produces will let that be absorbed very quickly. This is just one of the treatment tables. It looks confusing, but this is what we would do for a lot of decompression sickness or carbon monoxide type cases. You take the patient down in a short period of time. IO means the inside observer. Someone's always inside their chamber with them. This is when they breathe oxygen, so they don't develop excess nitrogen. This is an oxygen period and air period, oxygen, air period, oxygen, air period. The reason we do that is it prevents the possibility of an oxygen toxicity seizure. So by giving air breaks, you're basically resetting the clock, resetting their body. Then after that, typically they've recovered pretty well. You come up here to 30 feet, because again, too much oxygen is fairly toxic to the body. You can extend this if they're still improving, and then you continue on at 30 feet and come up. And so the treatment table for like decompression sickness, if you don't do any extensions here or here, is 285 minutes. So that's why I spent a lot of nights sleeping in the chamber. These would come in at 11 or 12. Actually, they'd call you about 6 or 7. You say, get in here. They'd get there about 11. Or they'd be transported there, get there about 11 or 12. You do your workup, you get them in the chamber, and then you're there until 3 or 4 in the morning. It's always worked that way. Second indication, carbon monoxide poisoning. And there's more reasons than one to treat carbon monoxide poisoning. A lot of people think all you're doing is getting rid of the carboxyhemoglobin. You're getting rid of that carbon dioxide and replacing it with oxygen. You're doing a lot more than that with hyperbarics. And so a lot of the emergency medicine docs don't understand that the reason to do hyperbarics, they say, well, he's in the ER, we've been giving him 100% oxygen for a few hours. His carboxyhemoglobin is down to 2 or 3. Why do we need hyperbarics? And I'll explain why. You've got the hypoxic stress from carboxyhemoglobin. As you know, hemoglobin binds preferentially to the carbon monoxide versus the oxygen molecule. But you have the cardiac and the central nervous system injuries are the most serious. It really correlates very poorly with the initial carboxyhemoglobin levels. Slow exposures to low levels can be very serious. It's really a function of the duration and concentration of the carbon monoxide exposure. If you've got a carboxyhemoglobin of 25 to 30%, you almost certainly will have cardiovascular compromise. This is the reason why you want to treat someone, even though they've been on 100% oxygen, their carboxyhemoglobin is fine. Late neurologic sequelae, up to 50% of people, and this is very severe, not just memory problems, ataxia, concentration, the whole spectrum, everything. And beautiful studies that document this. Up to 50% of these people, if they had a fairly significant initial exposure, will have this late neurologic sequelae. Carbon monoxide effects are more than just the hypoxia. I'll explain that. It's also lipid peroxidation. The carboxyhemoglobin molecule actually attaches to the myelin sheath and continues to damage the nerve and perpetuates itself. It causes this inflammatory reaction that just keeps going and going until you shut it off. And hyperbarics is the only thing that shuts that off. It's a reperfusion type injury, an inflammatory response, and also can affect the clotting mechanism. You get these free radicals that build up, and it just keeps going and going and going. And that's why you may have given them 100% oxygen, they may seem fine, and 2 weeks later they're getting worse and worse, and it just perpetuates, it gets worse and worse and worse. That's what I mean, late neurologic sequelae. Over 50% of these people, if they have a significant exposure. Now, small exposure, that's fine. So absolute indications, any evidence of cardiac ischemia, pregnancy, and the reason being the fetal hemoglobin has a much higher affinity for the carbon dioxide molecule. So mom may be looking fine and doing fine, and the baby's in severe distress. So any pregnancy, elderly with less reserve, any history of unconsciousness, ataxia, or altered mental status, absolute hyperbarics. Doesn't matter what their carboxyhemoglobin is now. Those are the people that are going to get delayed neurologic sequelae, and if they have metabolic acidosis. This is a picture of a brain hemorrhage from carbon monoxide poisoning. Hemorrhages delayed. There's a thrombus from carbon monoxide poisoning. This is someone who survived 3 weeks severe carbon monoxide poisoning. You can see some of the hemorrhage around here. And here's one where it went on for 5 weeks, how widespread it is. It just keeps perpetuating, keeps going, keeps going. Hyperbaric shuts that off, stops that. But you got to get them within about 24 hours or you're not going to accomplish much. So it accelerates the carbon monoxide dissociation from hemoglobin, replaces it with oxygen. It oxygenates the ischemic tissues, particularly in the brain or the heart. So any CNS, cardiac problem, remember? It helps produce ATP so that the mitochondria can factories can keep producing energy. Stops this lipid peroxidation, this inflammatory reaction, and PMNs adherence, reperfusion. PMNs stick to the vessel walls and create this inflammation, and it decouples that. So it prevents this delayed neurologic sequelae, and there's a very good randomized controlled article that showed how much it reduced it by. I don't think I talked about it here, but I think it reduces it by about 2/3. Early treatment is the key. Usually 3 treatments within 24 hours, but the first dive is by far the most important. Subsequent dives just minimize some of the effects, but the first dive is the really key. This is the study. This is the Weaver study. It was in the New England Journal of Medicine. Cognitive sequelae, 6 weeks, 6 months, 12 months, memory and concentration. This is the people that were not treated with hyperbarics, the percentage of patients that had problems, and the percentage that did not have problems. I'm sorry, the percentage that had problems that were treated with hyperbarics. Cuts everything in about half. You have to understand this is a very powerful study because the treated patients were the worst ones. These were the worst patients, and yet we reduced it to half. These were the less severe patients, and they had twice the problem.
Okay, I have to ask a question before I begin.
Yeah.
Does that mean that they're gonna make it like a standard, that if someone hits the ER and they have carbon dioxide poisoning, or they have this, that we're going to automatically ship them over to the...
No, they have to meet those criteria.
They have to meet those criteria.
No, not everybody. But I've lectured at many of the poison control centers about this. In places where there's hyperbarics readily available, like San Antonio, most of the ER docs are well aware of this and will consult. Places where they're not familiar with it and they haven't trained with it, they might not. Third indicator, yeah, yeah.
I just have a question on a slide. It said the one on why it's related with the carbon monoxide poison. What is PMN? I'm sorry. This
Uh,
is not
Polymorphonucleosides. The PMNs are a type of white blood cell.
Thank you.
Plus the Clostridias, the gas gangrenes, this is just a gram stain of it. This is a wound care type of thing. Hyperbarics is very important for gas gangrene. This is the typical tight bronzing skin. You get bullae, they become black. And you actually, when you take x-rays, you can actually see the gas feathering between the tissues. You don't see a lot of this, but I trained for a while at Baltimore Shock Trauma, where they get an awful lot of these. And the results really are amazing with hyperbarics. Now remember I said Hyperbarics is only primary for decompression sickness, air gas embolism, and carbon monoxide. This is adjunctive. You got to have surgery. You got to get rid of the dead tissue. So this is one of the things they typically do. They keep cutting and cutting until the tissue bleeds and is healthy. It may look okay, but there's no bleeding. They'll just cut and cut and cut until they finally get the healthy tissue. That tissue's all dead. Just doesn't look dead yet. So they have to cut until they get the healthy bleeding tissue. Now, the alpha toxin advances very rapidly, and that's what does it. Hyperbaric stops the alpha toxin in its tracks. The best thing you can do is do hyperbarics before surgery, but surgeons always have a fit. Oh, no, we have to do surgery. So if you can get them right after surgery, typically they don't need nearly as much debridement. They don't lose nearly as much tissue. You get a lot more recovery. So most of it's Clostridium perfringens, very rapidly progressive. They get this massive tissue death and extensive edema, gas production. You often see it in motor vehicle accidents. Clostridia gets introduced due to a trauma or a fracture. And it usually starts within 6 hours, so it's very rapid. The treatment is wide operative debridement, antibiotics, and hyperbaric. And we don't need to go through all this. But it's bacteriostatic. It stops the bacterial growth and it activates the toxin. Delays in treatment can be fatal. It decreases amputation rate from 75 to 25% among patients with gas gangrene of the extremities. This is a study. Went from 75 to 25% amputation rate. Old study. Sorry, I haven't updated my references. Number 4, crush injury and compartment syndromes. You ever seen these? Particularly here, somebody gets hit with a baseball, and get this big swelling. The fascia prevents the tissue from going anywhere, and so it cuts off all the blood and all the oxygen to the tissue, and the tissue dies. Remember what hyperbarics does? Stops ischemic reperfusion, which is one of the things, and it reduces edema, reduces swelling. So that's why it would be good. Plus you're oxygenating those tissues. Sorry, I couldn't come up with anything except for crush, except this guy's crushed. Sorry to interrupt. It's your wife on line 1. Something about a mistaken number on your winning lottery ticket. So the intact fascia prevents expansion of the injured muscle. You've got all this swelling that's expanding and the fascia is stopping it, so of course it's cutting off circulation. Pressure increases. You can get enough swelling and hemorrhage to compromise circulation and neural function. This is just a little graph that shows as compartment pressure increases, blood flow gets cut off. It's kind of obvious, but it's a study that shows that. So as your pressure increases, your blood flow basically almost gets to zero through that area. So primary treatment is surgical, open up the fascia, fasciectomy, so allow the tissues to expand. But it reduces the edema, supports that ischemic tissue, stops that ischemia reperfusion, that magic word I keep talking about, and inflammatory reduction. This is the ischemia reperfusion injury. You get ruptured vessels, and these vasoactive substances from white cells and red cells leak out into the interstitial area and cause a constriction of the neighboring vessels. And this self-perpetuates and goes on and on. And as the blood gets cut off, it gets ischemic over here. It just keeps going, and this hyperbaric stops this. It stops that whole process. Effects of hyperbaric on crush injuries. We don't need to go into this. This just shows that I don't want to be going too long, but this just shows that the oxygenation of the tissues increases greatly with hyperbaric. Reduces the compartment pressure as this is the hyperbaric. The absolute compartment pressure doesn't go up very much, and this is without hyperbarics. Same cases, similar cases. However, the muscle damage continues with that ischemia reperfusion. The hyperbarics, it just kind of goes here another level on. Decompression sickness, I'm not going to talk about that much. That's what we do a lot of in the Air Force. Not only diving, but altitude decompression sickness. If people fly high in the altitude chamber, we take care of the U-2 pilots out of Beale. They're the ones that fly at 50,000 feet doing spying and stuff, and they actually have space suits on, but they're not pressurized suits, but they're not 100%. So that's what we do a lot of, but that has nothing to do with wound care, so I'm not going to talk much about it. But this is the U-2 pilots, and that's what they actually go up in when they fly their missions. This is where we treated most of our cases. There were people doing the altitude chamber. When you're on active duty flying status, you have to redo this every 5 years, or when you initially train. It's supposed to train you to recognize hypoxia when you're flying, that you need to turn your oxygen on, what the symptoms are. Well, we get a lot of decompression sickness cases from this. Certain schools, certain classes, when they go through, you can just predict, okay, I'm on call this week, and I've got which class going through? Okay, we'll be doing 3 or 4 people this week. Yeah, and a lot of times it's just vague symptoms, but you treat them just to be safe. You say, is it decompression? I don't know, but might as well be safe and treat it. And basically what an altitude chamber is a vacuum chamber. It just pulls air and oxygen out of the chamber. And as everyone knows, nature abhors a vacuum. Treatment for altitude decompression sickness is return to sea level, but not as rapidly as this, hopefully. Typically use a Navy treatment table 6. You saw the Air Force one, you saw all those bars. The only difference between the Air Force and the Navy one, the total time, the total amount of oxygen is the same. They just split it up differently. A lot of people like to do this because they don't have to keep putting the mask on and off, on and off, on and off. But there's a little more risk of oxygen toxicity. Otherwise, they're basically the same. So it's about 5 hours once you get them down and before as you get them up. So typically count on 5 to 6 hours. Problem wounds. This is where we really use the hyperbarics for the wounds. Problem wounds are defined as wounds that aren't progressing in 30 days, that have other variables. I don't have the exact definition on top of my tongue, but have other variables and comorbidities that aren't progressing. How does hyperbarics help? It supports the hypoxic tissue. The center of a wound, a problem wound, is typically hypoxic, and no healing goes on if it's hypoxic. So you're giving it some oxygen, you're allowing the vasculature to grow into it and proliferate. You're making collagen. Fibroblasts can't make collagen without oxygen. You're reducing edema, you're doing the growth factors, reducing inflammation, enhancing white cells, killing bacteria, all this stuff. And that's just a few things that it does. When tissue oxygen equals 30 to 40 millimeters of mercury, white cell killing is enhanced, fibroblasts occur, which makes collagen, and collagen can be laid down, and capillary growth occurs. Below 30 millimeters of mercury, none of this happens. And if you test with it's called TCPO2 or a TCOMS machine, the majority of chronic wounds, the center of a wound would be about 0 to 2. So you're getting none of this happening. Now maybe the periphery will have it, the center will have nothing. Hyperbarics allows that oxygen to get in there and allow these processes to start. That's just, you can't have a talk without a few ugly pictures. These aren't much, but these are just some problem wounds that we were able to heal. Sometimes they're chronic. We've seen wounds that would come in 2 or 3 years old. Somebody's about ready to have an amputation, or they've given up, they've tried everything, and they've been to wound care centers, and we would use hyperbarics, and we'd heal them 95% of the time. The few we didn't were usually the severe arterial disease cases that were last resorts. I'm not saying hyperbarics is needed for everything. We only use hyperbarics on 5 or 10% of our patients. Good wound care is what you use most of the time. But when you need it, it's an amazing tool. Oh, these are just more pictures of dehisced wounds and so on that weren't healing and able to heal them up. This is unfortunate. Sadly, is not an uncommon occurrence. We would see people that have cast too tight or something that would break down. And we had one guy that had a skin graft, and by the time the surgeons were done with him, they kept poo-pooing us away. We kept saying, "Well, I think you're putting these dressings on too tight, et cetera, et cetera." Then they, of course, sent him to us to fix. It took us a year. He looked like the Terminator. All the exposed tendons everywhere. And it took us a year to heal him. Could have been prevented. We kept trying to go to the bedside. No, we don't need you guys. You guys get out of here. And so a year later, we finally got to heal him. But this is the kind of case where we get off. Now, is hyperbarics alone to think? No, you need good wound care along with this too. You're not going to do this just with hyperbarics and accomplish much. And that's why I have a problem with facilities that only do hyperbarics and don't do wound care. You're only doing half of it. And like the surgeons, I mean, anything that comes in, when you have one modality, you're going to do that modality. When you send a back pain patient to a surgeon, what are they going to do? They're going to do surgery. They're not going to do rehab. That's not what they do. So you need to have both when you send to a center. Oxygen paradox simply that hypoxia stimulates wound healing processes, buildup of bone, collagen, etc., and blood vessels. But hyperoxia also does that. Basically what I'm saying is you need both. You need to have increased oxygen followed by lack of oxygen. That's what really stimulates it. If you had somebody in a hyperbaric chamber 24 hours a day, first of all, they couldn't tolerate it. Their lungs couldn't tolerate the oxygen, or they'd have seizures. But let's say they could tolerate that. It wouldn't be the same as that increase in oxygen followed by relative hypoxia. That's what drives these processes. That's why you're saying, well, you're only in the chamber for an hour or an hour and a half. Yeah, you need that period in between. That's when all this stuff starts happening, all these chemical processes. That hyperoxygen and then relative hypoxia. That's what gets it all going. So you don't want to dive anyone more than a couple times a day in most cases. Usually one time a day is fine. That's what gets it going. It has to be intermittent. Antimicrobial effects, it enhances white cell killing, inhibits toxins, inactivates certain toxins, it's bacteriostatic for certain bacteria, and stops antibiotic transport across, it helps antibiotic transport across cell walls. One of the experimental indications for hyperbarics is chronic Lyme disease. And the reason it seems to work is because the Lyme disease organism, which one is it? What's the name of something Borrelia, I can't remember what the name of it is. It hides out in some of the organs, in difficult areas like in the liver. And the bacteria, the antibiotic can't get to it. And hyperbarics, if you do it, it seems to allow the antibiotic to transport across the cell wall and kill it. That's what the theory is, and it seems to work for refractory cases. This was just an old study showing that oxygen is an antibiotic. Percentage of staph aureus killed in 1 hour. The PC, as the oxygen goes up to here, and then it basically stabilizes. The staph is just getting killed just by oxygen alone. No antibiotic, just oxygen, hyperoxygenation. It's killing the staph. This, I don't know why this was done, but this was a case where they did not use antibiotics. They had a dehyst right below the knee amputation that was infected with MRSA. And using hyperbarics only, again, I don't know why. I don't know why they didn't use antibiotics. But using hyperbarics only, after 1 week and after 1 month, it was basically healed. It was still consolidated. I don't know why. I don't know the history as to why this was done. This was before I was out of Travis. About a year before I was there. It affects the white cell adherence, TMNs, those white cells. And it seems to be most effective at about 2.8 atmospheres, which is where we treat. A lot of the monoplace chambers don't go that deep. They only go to about 2 atmospheres. So that's the studies around it. It's not quite as effective. We don't have any real studies comparing multiplace chambers and monoplace chambers. But the multiplace chamber, we take them deeper. It's safer to go deeper. So according to this study, it's a little more effective. How hyperbarics works, it promotes the white cell function, phagocytosis and migration. And when leukocytes are phagocytizing bacteria, oxygen consumption is increased by 15 to 20 times. So you've got to have that oxygen for this to happen. This is an old study. There's been a bunch of other studies that just show how hyperbarics is very effective in healing diabetic foot ulcers. And again, I don't want to go into depth because I know you guys don't want to be late. I don't want to keep you late. Another study showing wound size with hyperbarics greatly decreased over a rapid period of time compared to controls. Now, does every diabetic foot wound need a hyperbarics? No. Out at our center, like I said, we treated maybe 10%. But if they failed to progress, or they weren't getting anywhere, or they had a lot of comorbidities, then we would certainly consider it. The commercial places, they want to make money, and Hyperbarics is a money maker. I'm not faulting places, but sometimes they will treat things that we didn't do, because we didn't need to. We were in the military, we treated what we felt we needed to. The other advantage we have is we can treat the experimental indications and not worry about not getting paid by the insurer. So that's why we're doing a lot of the experimental stuff. Yes?
What is the cost?
Sorry?
What is the cost for average?
It depends on private insurance versus Medicare. Typically, each dive is around $400 to $500. The typical treatment is around 30 dives, sometimes more. So do the math, it's quite a bit of money. The hospital gets the majority, the facility gets the majority of that money. The doctor gets about $100 per dive that they supervise. Exceptional blood loss anemia, that's indication number 7. Hang on, there's only 13. This one I'm going to go into just very briefly. It's only when you have severe hypoxia, hemoglobin less than 3.8, transfusions unavailable, or their blood's refused, or they have blood incompatibilities. It's to allow the tissues to remain oxygenated long enough for the body to build up enough hemoglobin. I only had one referral for this ever. It was a Jehovah's Witness that was pregnant. No, she wasn't pregnant. She had multi-organ failure. Yeah, that's right. She'd had bleeding from postpartum or something, severe bleeding. She had multi-organ failure. She was like 2 hours away. All her organs were shutting down. They wanted to send me out. If she gets here, forget it. So I've never actually treated it. And again, as I was saying, you completely oxygenate the hemoglobin. You can do that with a mat. When you do the pulse oximetry and you're 98, 99%. You're not oxygenating that, you're oxygenating the plasma. And that can continue to carry oxygen much farther, 20 times the distance in the tissue. So that's what you're doing with hyperbaric. So just again, this isn't something you're going to see very often, but 70% survival with hyperbarics in studies. Intracranial abscess, another one that I think I've treated once, pretty rare. Some of these empyemas and abscesses, they typically have about a 20% mortality. The only times we would do it is the multiple abscesses, deep location, critical function. They're poor candidates for surgery or not responding to antibiotics, but we've only done it once. It's not common. Like I said, multiple abscesses with critical areas, so on. Necrotizing soft tissue infections. This is a little bit different than the Clostridia infections. It's a subcategory. And we saw a lot of these, the Fournier's, gangrene, and other things, necrotizing infections. The flesh-eating bacteria. A lot of people don't think to refer for this. This saves lives, it saves limbs. It really does. It stops the advancement. So you see these people with the flesh-eating bacteria, think hyperbarics, because your doctors won't. They won't think of it. Can be multiple infecting organisms, typically severe if they have vascular disease, diabetes, or immunosuppression, which is most of people in San Antonio. It causes local tissue hypoxia, the end arteritis, basically inflammation of the vessels. It just basically they clamp down, close, and the blood gets through. The white blood cells are depleted. You get toxin effects. As I said before, PMNs don't work unless you have enough oxygen. So these are the syndromes you will see. They're just basically different names for almost the same thing. Fournier's is down in the scrotal or inguinal area. We saw that fairly commonly in the necrotizing fasciitis. Get some real good results treating them. This is a typical case. Go here, and then they get the swelling and bulging, skin color change. They get bola just like the Clostridia. And this is the treatment typically. They have to remove all the tissue and then skin graft. But with hyperbarics, you'll save lots of tissue. You'll save most of that tissue. It's adjunctive again, complements surgery and antibiotic, reduces mortality and spares tissue. Refractory osteo, this is an important one. Acute osteo is not an indication for hyperbarics. Not to say it might not help, but it's not needed. Antibiotics are usually all that's needed. But the refractory cases, it seems to be really beneficial. It's just infection in the bone. Doesn't seem to be going away with antibiotics, even prolonged courses of antibiotics. There's a bone scan showing positive there. And it persists after appropriate management. It usually has some kind of host compromise, but I've seen it even in young people. These are some of the factors, systemic and local, and everything. Lymphedema, venous stasis, malignancy, tobacco use, renal failure, liver failure. You can read the list. This is an old study, but this is just one example that hyperbarics is synergistic with many antibiotics. Not all antibiotics, but many of them. Showing the bacterial count with the antibiotic alone, and then antibiotic with hyperbarics added. You see how much smaller the bacterial counts are. It works synergistically with antibiotics, a lot of antibiotics. This has no value in non-refractory. That's questionable, but it's not really needed. Treatment is surgery, antibiotics, and hyperbarics. And the arrest rate, this was an interesting study. This is a study in previous failures that have tried antibiotics and surgery and not been able to do anything. 60–85% stopped with the hyperbarics added. That's pretty impressive. These were all previous failures. This is what we did a lot of. Some centers here do it depending on where they are. Most centers treat mainly diabetic and problem wounds. The delayed radiation injuries were sort of our bread and butter. Hyperbarics is really the only thing that helps these people. When you get radiation injuries, typically radiation therapy, over an area, the blood vessels get very affected. They sort of scar and close down. They get very hypocellular, very little cell growth, and it's very easy to get wounds. You get wounds that they won't ever heal. Also, deep tissues, the colon, the bladder. If they got radiated for cervical cancer or for prostate, and the tissues end up sloughing. They have a lot of bleeding. Hyperbarics brings new tissue growth in there and new blood vessel growth. And it's the only thing it does. So typically these are delayed injuries after a latency period, at least 6 months. Injury continues over time. So maybe they had radiation therapy 10 years ago and they were fine for 5 or 6 years, and then things got worse and they continue to be getting worse and worse. It tends to accumulate. They get this endarteritis where the vessels, as I say, get sclerotic and close down, and they have inflammatory process as well. This was actually a protocol. There's 2 protocols that were created called the Marks protocol by an oral surgeon here in San Antonio. And he showed how this is the vascular density, the blood vessel density of normal tissue, healthy tissue. And this is just typical cases that have been radiated. So the vascular density may be less than 30% of normal. This just shows what hyperbarics does. And this is where our protocols are based on. You start treating at about the 8th dive. All these things have prepared the tissues, and the tissues start producing new blood vessel growth. And this goes all the way up to about the 20th dive, and then it plateaus. And so we based all of our protocols. There's a 20 and 10 protocol and a 30 and 10 protocol on this. And this, you can treat till the cows come home. It doesn't get back up to normal, but it goes to 80%. This is a picture, electron microscope, of radiated tissue, the vascular density. This is the same magnification while hyperbarics is going on. All the new blood vessels growing. So this is just saying the incidence of radiation necrosis, particularly in the face, depends on the amount of radiation that's received. And if it's over 70% grays, it's typically about 9%. A lot of them will heal, but the ones that don't, they need to be referred for hyperbarics. Osteoradionecrosis is one of them we treated all the time. People that had head and neck cancer and had radiation therapy. If their teeth get bad, they don't have the salivary flow, they don't have the blood flow. Their teeth get bad, they need to have teeth removed, or they end up with big ulcers. A lot of the oral surgeons that are well aware of hyperbarics will not touch these patients until they've had the hyperbarics to get new blood vessel growth and new tissue growth, because their outcomes are so bad. This is our protocol for that: 20 preoperative dives, 10 postoperative to help with infection and swelling. When they have frank osteoarteritis necrosis, in other words, exposed bone, that's 30 to 10. And I sort of touched on why we came for those protocols. This is a little bit out of date. This is 85, but at the time it was thought that penicillin was the treatment of choice for osteoarteritis necrosis. They've now got some other regimes. And so they did a back-to-back of hyperbaric group versus a group treated with penicillin. And 30% of the penicillin group ended up with osteoarteritis necrosis versus 5% of the hyperbaric group. Yeah?
Did you ever use hyperbarics to treat OMJ induced from bisphosphonate?
OMJ.
Osteonecrosis of the jaw.
For bisphosphonate induced?
Mhm.
Yeah, we're doing research on that. It's not as successful. It's a different mechanism altogether. We treated about 5 cases out of Travis where I was, and we were successful in about 4. But the literature across the board, which is somewhat limited, but there's been maybe 20, 30 cases out there. It's 30 to 40% have benefit. Not nearly as successful as this. Again, it's a different mechanism. Not as much the vascular problem. So that's just a case of osteoarteritis necrosis where it's actually eroded through the neck. And I did a graft, and with hyperbarics able to get it healed. Other things we treat: soft tissue necrosis of the head and neck, like larynx. We reduced delayed healing from 55 to 11%. Serious complications greatly reduced. Chest wall necrosis, we'd get people that have breast cancer, have wounds that won't heal there down the road. Typically can resolve 50 to 75% of them. Radiation cystitis is the most effective. These are the people that are passing blood clots out of their urine, severe problems, sloughing tissue. There is no good treatment. They can infuse formalin or some other things up there to try and seal the tissue. Hyperbarics actually heals it, average of 80% of the time. So these patients were so happy. They'd be passing huge blood clots. By the time we were done, they were asymptomatic. And we say that. Radiation proctitis and enteritis, not as good. Averages about 50 to 60% improvement. The people passing blood and sloughing tissue from the bowels, and chronic diarrhea. The pelvis and perineal areas from soft tissue radiation damage, about 50%. And same with extremities, 60-something. So CNS, people that had radiation to the brain because of whatever reason, some improvement. We were real mixed. We were like 50-50. Some people we helped, some we didn't. The dental prophylaxis we kind of talked about, but the average for the dental people before they have again, I know I'm sort of fumbling. These are people that had the radiation therapy to the face or neck, had bad dental caries, and they need to have extractions. They didn't have osteonecrosis yet. They didn't have exposed bone. Before they would have these teeth removed, we do the hyperbarics, and about 90% would have success. If you didn't do that, if you didn't do the hyperbarics, 50 to 60% would fail. Would go on to osteonecrosis and often have to have their jaw removed. So that's why oral surgeons that are trained with hyperbarics, that are familiar with it, that use it, they will not touch these people until they've had the hyperbarics. And we had people that were so obsessed with it that we would treat them 19 times and say, oh, they're okay, they're fine. You know, it's not necessarily 20 is a hard, fast number. They want to, oh no, we're not going to touch them until they've had 20. You know, just that's serious about it. This was a case of mine. This woman had a wound on the bottom of her mastectomy site for about 3 years. And it took a while, but after a month, we finally got it to heal. Now, is that normal tissue? No, that's still radiated tissue, still very friable tissue, but it healed. You're not going to get these radiated soft tissue lesions to be back to normal, but you can improve them enough to get them to heal. Skin grafts and flaps. We gotta get moving. I don't want to be late. A rubber stamp we all need. Grafts detached from the blood supply. For example, here's a left temple basal cell carcinoma. You remove it. During surgery, it's found to be a lot larger than expected, so you have to do this graft. Well, a lot of times they start to fail. They get real dusky and purplish. That means the blood flow is not going out. The tissue is going to die. Hyperbarics helps stop that ischemia reperfusion injury, which is what's going on. Post-surgical healing, excellent. Some plastic surgeons, this is not approved by most insurers, but a lot of plastic surgeons will require hyperbarics after, because their scars are less and the healing is much faster and much better. You have to pay for that yourself. The insurer won't pay for it. A flap, just difference between flaps and grafts, not important. Traumatic flap wasn't healing. Before surgery, they had to debride it, and primary closure, and then after 12 preoperative and 5 postoperative hyperbaric treatments. Can't even see that very, can you? It's too dark. There's another one, a basal cell carcinoma. It just really helps outcome. It's just showing, again, I'm trying to hurry through. Hyperbarics helps survival of skin flaps. And you don't have to do 30 treatments. 3 treatments seems to be about all you need. It stops that inflammatory pathway. You don't have to treat a whole bunch of time. This is, 0 treatments, these are percentage survivors. 1 treatment, 3, 5, 13. Not much difference. 2 or 3 treatments, all you need. So grafts, it shortens the healing time. Flaps increases their length, increases survival, et cetera, et cetera. This was an interesting case I did. This was a little 4-year-old girl who was attacked by a pit bull, ripped off a quarter of her face. And this flap was dying. I've got a picture. This was turning black. The oral surgeons jumped on it and called us in, called hyperbarics. We not only dove her right away, they call it a dive, hyperbarics. She's going down, so they call it a dive. But we also use leeches to reduce the venous congestion, and this was her outcome. Now, when she's older, they'll have revision of the scars. But this would have been a skin graft. This would have been different tissue, different texture, different sensation, and she was pleased as punch. Thermal burns, laundry list of things that it does. I'm not going to go into that. It improves epithelialization, reduces burn mortality. This is a case hyperbarics provided. This is after just a couple dives. That's after about 7 dives. And I wish I could show you the final picture. I don't have it. She's a gorgeous girl with her hair all grown back. So this is some of the experimental uses. We're almost toward the end. This is not a comprehensive list, but these are some of the things that are being used. Multiple sclerosis, not sure. MI, if it's fairly acute, you're perfusing, you're giving oxygen to ischemic tissue, so it makes sense to limit the damage. But very few people will put them in the chamber. They're always in the cardiac rehab unit, so you don't have enough time. Same with the stroke. It'd have to be fairly acute. You're going to re-oxygenate ischemic tissue, so you're going to have less damage. But most of the people won't put them in the chamber. They won't let them go. Spinal cord injuries reduces edema, swelling, brain injuries. Retinal artery occlusions, that is the one that's going to be the new indication. People with acute retinal artery occlusions, 80% of the time we can get their vision back versus all the conventional treatments combined, less than 20%. Sudden hearing loss, it's used a lot in Europe. Our studies have been up and down, so not sure. Frostbite, some real good cases. That's, again, it's an ischemic reperfusion injury, so it makes sense. Brown recluse spider bites, within 24 hours, it seems to inactivate the toxin and prevent the further damage. 1 dive only, okay. The bisphosphonate-induced osteonecrosis, again, about 50-50. These are the chronic refractory Lyme disease, and then this one. This is the one I would love to do more research on if I get back to the chamber. Crohn's, the chronic refractory Crohn's and ulcerative colitis. Not that many cases done. We did 3 or 4 out at Travis. There's a few in the literature. Every single case that I have seen or that I have done, 100% cured. These are the refractory cases that can't use the medicines anymore. 100% cured. Well, what is Crohn's disease and ulcerative colitis? It's chronic wounds throughout the GI tract. That's what hyperbarics treats. I can't get enough cases to get a big randomized controlled study, but like I said, I've seen about 10 cases myself or in the literature, and every one of them cured. Yeah.
Are you able to do anything that is going to the TBI cases come out of data?
TBI is the biggest thing that's coming through. There's a lot of money. There's a number of private centers that are going to start doing research. I'm working with a committee right now throughout this military and the VA, Army, Navy, VA, etc., that's developing the protocol, and there is definitely going to be going on. I think you're going to see some great. It's not an emergency. This was 21 days after. Never been reported like this. See the black? These are proof. Just normal sensation, everything. Dead tissue back to life. If you remember, I did mention possible side effects. This is sort of our Bible. Comes out every few years. Actually, it's overdue. This will have the 14th indication, I believe, when the new one comes out. And this is a real picture. It was in the paper. Look at this thing. Any questions? I think I'm pretty good. I did pretty good.